Dr. Holtzman will be starting his conversation. We're lucky to have him, so thanks again, Mark.
When you're switching from one opioid to another, you have to take into account that they're not equally potent. So you need to understand the relative potencies of opioid analgesics and then try to calculate out the appropriate dose when you convert from one opioid to another. So for this, you need to take into account the patient's medical conditions. So what's their renal function? What's their liver function? Do they have a history of sleep apnea? Are they morbidly obese? Are they taking concurrent sedating medications like benzodiazepines, antihistamines, antiemetics like Phenergan or promethazine, something like that. So you need to take all of that into account as well. So you can see if they were able to stay comfortable within the switch. So the main objectives were to help them identify patients who are good candidates for rapid conversion using an opioid calculator. And then, monitor the patient closely, but go ahead and use the dose that you calculated. And usually in the inpatient setting where I work, that's not a problem. The patient's closely monitored. In a setting where your patient's in the outpatient setting and it's urgent, then you need to look at the big picture. Is the patient in a situation where they have caregivers around that can kind of monitor the patient for you? So if you give a little too much medication and they get sleepy, they'll call you as the physician and say, hey, I'm a little worried about the patient, they're getting sleepy, or the nurse practitioner, somebody that can help the patient adjust the dose and help the caregiver adjust the dose, or tell them to stop it and come back to the to the clinic and we'll reassess. What we're looking at is that you can identify patients that are good candidates for opioid conversion using opioid calculators or tables. In terms of identifying those patients, also learn how to use these calculators for other patients. For instance, patients that have substance abuse disorder, patients that are having adverse effects to opioids who want to come off the opioid completely. There's a physician that I quote all the time named Sebastiano Mercadante. He's published on this area significantly and has shown that patients that have severe pain, that are on chronic opioid therapy, that are opioid tolerant, meaning they take more than 60 milligrams of morphine a day for a week, are good candidates for his 20% dose. And so what he's found is patients that are, say, taking 300 milligrams of morphine equivalents a day and they come into the ED and they're in severe pain, those patients actually do pretty well if you give them the equivalent of 20% of that all at once for their breakthrough pain episodes.
You might be surprised.
For identifying a calculator that works, first of all, you have to have a calculator that's transparent. And when I say transparent, that means they share the tables with you that they're using for their calculations. And hopefully they share their references as well for those tables. It's not urgent to do an opioid equianalgesic conversion. Then I would suggest you can use the calculators or the tables to do a guesstimate of where you want to take a patient in terms of the conversion, but that you can be much more conservative and slow in your decisions and in terms of how you implement those decisions. That way, your chances of overdosing the patient or underdosing the patient are significantly lower.
I'm a nurse practitioner here at UIHS.
There aren't very many pain management specialist pharmacists in the United States. We're trying to be a beacon of light, spread the knowledge that we gain and share it as much as possible to help everyone that lives in Northern California on a bigger level throughout the world.